Oncology is relevant, obviously, but it's more relevant to your further career. As an F1, you've probably been faced with some situations. You're not going to be dealing directly with treating oncology patients. So I'm just going to go. I selected just the 4 types of tumors which I thought you could encounter quite often on the ward. So there are bits you probably know, like basic science. I try not to put too many things in there because it can be a bit boring, you know. Then there's a bit of clinical presentations, and in the end, I just intend to just talk you through, a few situations you might encounter on the ward, which are basically dealing with patient diagnosed with cancer. Right, just hopefully this will work. By the way, my name is Marina, and I'm currently in my last rotation, which is a colorectal, and I'm in academic oncology next year. So that's right, the interest basically. Right. Okay. So any time, any questions, just feel free to interrupt me, or if you find it irrelevant, just I can speed up as well. Or right. Okay. So just a bit of interest to set the ground. Basically, oncology. Where does it come from? Cancer word, we know a lot of it. It's just a reminder, basically, that it's something we know like 500 years before Christ, and the first descriptions actually of cancer have been made by the father of medicine, who was talking about carcinomas and carcinoma to talk about ulcerative and non-ulcerative tumors, just to realize basically how far it all goes in the history. The characteristic features of any cancer basically is unregulated, uncontrolled cell growth and invasion capacity, which is what defines as well benign and malignant tumors. I'm sure you know this about what features do cancer cells display. I'm sure you've been through that a bit in science, so just quickly, basically their proliferation is regulated. They have less capacity to differentiate themselves, so basically they just stop at some point in the process of differentiation and can't go any further. They're not undergoing the apoptotic death, which is programmed and they also display genetic instability, so many mutations occur, and once some mutations have occurred, we're more likely to see others as well. They also have the capacity to invade the tissue, and this is partly due to the loss of adhesion. Metastatic capacity, and one which is very important in ABG, which is the background of immunotherapy today, is that basically they're just evading the immune system, meaning that our body is not able to recognize them as foreign cells anymore. And of course, the most important thing as well is that in cancer, there's so many things we don't know today, but one thing we know is that it is a multi-step process and multi-step changes. So I just chose breast cancer because this is like the leading cause of death in women, is it? And just to give you an idea, an annual incidence in the UK is like something like 40 to 50,000 per year. And like a little more than 1 million annually. This is in the worldwide setting, so it's quite a widespread disease, is it? When we talk about breast cancer, one thing we should just say is that basically 5 to 10% are hereditary tumors, and in the rest, so meaning in the rest 90% are non-hereditary tumors. They're also divided into non-invasive. You've probably heard about carcinoma in situ. You guys know a bit what it is. Okay, I won't go further then. And invasive, which the most frequent are the ductal breast carcinoma, accounting for something like 80%. I won't go very much pathogenesis. I mean, that's something obviously you can read, but I don't want to go into too many details. One important thing is basically that we have 4 main subtypes of tumor: luminal A, luminal B, and something you've probably heard about, HER2, which are all caused by different genetic and epigenetic changes, defining, once again, different prognoses. and different response to different treatments. So nowadays, every treatment almost in oncology is based on molecular changes which help define prognosis and response to treatment. Among the prognostic factors we have, this is something relevant to us, is obviously the lymph node status, meaning have any lymph nodes, and if so, how many of them have been invaded by the cancer cells, the size of the tumor, the lymphatic and vascular invasion, and the histology grade. This is like applicable to any type of tumor, but specifically for breast cancer, we have relevant what we call overexpression of estrogen receptor and progesterone receptor, which are prognostically important as well, and HER2. Do you know you probably know that some cancers are hormone sensitive. You've probably heard that, and hormone sensitivity is due to the expression of estrogen receptors or progesterone receptors. So those tumors can be treated with hormonal therapy as opposed to non-hormone producing and non-receptor expressing tumors. Another important type I just mentioned, you probably heard about HER2 positive tumors. They account only for about 25% of all diagnosed cancers. And one important thing is that the overexpression of HER2 is associated with a poor prognosis of those tumors. And one particular thing is that this receptor HER2, usually a receptor binds a ligand, so that's how the downstream signal is conveyed. But in this case, he's activated not by a ligand, but basically by the dimerization with another receptor of the ERBB family, and initiates then an oncogenic signal with angiogenesis, proliferation, and decreased apoptosis, which are once again just the backbones of cancer pathogenesis. How do we manage breast cancers? Well, first of all, the background is surgery, is the primary treatment for most of the time. We first get a biopsy, obviously, of the tissue when we analyze it histologically, and this is how we determine the status, whether the tumor is hormone producing or not, or hormone controlled or not, which is determined by the expression of progesterone and estrogen receptors. And obviously this guides prognosis. The next step is to what we call, have you heard about lymph node sentinel biopsy? It's still controversial worldwide whether it's actually really, especially in melanoma, whether it's actually worked, but in breast cancer it's still practiced, and it is still predicted. It has a predictive value, so we evaluate how far the tumor cells have spread and how many lymph nodes have actually been invaded and involved. So this will guide whether we're gonna just do a biopsy or we will have to, the extent of the resection we'll have to do afterwards according to the extent of lymph node involvement further. As I mentioned before, the hormone-positive tumors which express the receptors have a lower growth rate, so they have a mildly more indolent course and respond quite well to hormonal treatment. Have you heard of any hormonal treatment? Probably know at least one of them. Yeah? Someone said tamoxifen, that's right, that's the most famous one, and it's still the background of treatment. Whereas HER2 positive tumors have a good response to certain chemo agents like doxorubicin and trastuzumab, but it is once again, it is HER2 expression is a predictive factor as well as estrogen and progesterone receptors. That's all we can remember. We don't expect you to remember anything else. It's just for your own culture, and I think that's something even as junior doctors it's just good to know, because you probably hear about it if you're for example in breast surgery or on any other board.
With the HER2 positive tumours, if you treat them with the chemotherapy that they're sensitive to, does that then bring them down to some of the prognostic level of people who are HER2 negative? So in the long run, are they kind of then at a level, are they still worse off?
it is a negative predictive prognostic factor baseline. So in oncology, it's really difficult to say. No treatment actually brings you to the same level as someone who's not expressing the same. But for example, like if we talk about estrogen receptors and progesterone receptors, then they respond quite well. HER2 is a bit more, they are treated with chemo, but the individual response is really hard to predict because it will depend how much lymph nodes, how many lymph nodes have been involved, what the staging of the tumor is, the overall, so it's really, we can't really say that the therapy, you know, it will be a sign that they're more responsive to chemotherapy, but it doesn't guarantee that, you know, the treatment will be as good as...
I'll just add that the thing is, if you're HER2 PR or estrogen receptor negative, that's actually a poor prognostic indicator because you have fewer treatment options. So it's actually good to be positive. If you see what I mean? So if you're triple negative, then you're worse off than if you're actually positive.
So positive, yeah, positive prognostic factor is ER2 positive and PR positive because it means you're very likely to respond to hormonal treatment and you have a better outlook, prognostic outlook than others. As Shannon said, so the negative is always a bit more tricky because it doesn't mean you won't respond, it means you're less likely and you're less likely to be given that treatment as well in clinical setting. So there's a bit of non-fitting of the slide, but yeah. I thought then I'll just mention a bit about lung cancers, and as you probably know, how do we divide mostly lung cancers? The answer is there somewhere. Okay, so non-small cell lung carcinoma and small cell lung carcinoma, knowing that the vast majority are non-small cell lung carcinoma, and the most common histological subtype is adenocarcinoma. The other thing is that it is also cancer that occurs commonly in non-smokers, right? And we can say that it has a trend to be located peripherally on the peripheral fields of the lungs. It doesn't mean it always does, it means that there is a trend. Whereas small cell lung carcinoma represent 1/4 to 1/3 of all tumors and tends to occur in central parts of the lung. An important thing is also that it is associated much more with hypercalcemia. So you probably guys know when you see a patient with hypercalcemia on the ward, just what are your main differentials? Like, oh, these patients, right? Okay, we've done biochemistry and we've got a high calcium, but we have no clue what this is. So what should we be thinking of even? It doesn't have to be bone. Basically, hypercalcemia is a mark. For any hypercalcemia, you should query potential malignancy until proven otherwise. Right? Otherwise, you will do PTH and endocrine assessment. But this is a type of cancer that is quite commonly associated with hypercalcemia. Not all of them, but this is one, which is commonly associated. So as we see, it is quite often diagnosed at a very late stage. So basically, in more than 50% of cases, the patients have already distant metastatic disease. And what is of interest to us is how do those patients present, because it can be, we can have a patient on board who's just short of breath, but he's been short of breath for a while. Now here's some chest pain, cough. When you ask him, it's been ongoing for years. He used to smoke, then he stopped. He's coughing up, but sometimes a bit of blood, he's not sure, yes or no. He's tired, he's lost a bit of weight. So it's really non-specific symptoms that might be explained by, chest infection, that you might be thinking of something else. Also history of recurrent bronchitis, for example. So the main thing is, this is showing that basically those patients can present with something that is very common symptoms, and among your differentials, you always have to think of basically the worst, unfortunately. And what among the clinical symptoms and the clinical picture, what is directing you towards something else, for example? What is directing you towards something malignant in the history? We've got here, the symptoms.
Weight loss.
Yeah, weight loss is quite important. Never forget to ask about, because you see a lot of patients with COPD, asthma, chronic changes. So you actually sometimes might overlook just asking this question, which might be really relevant. And if you have a patient who reports weight loss and fatigue, because hemoptysis can be linked with other conditions, is it? But weight loss and fatigue are quite significant. It is likely that this patient will probably get a CT investigation, which makes sense. So it's just very easy to ask, but always think of. When a patient presents with metastatic changes already, he can present once again with bone pain, but bony pain everywhere. But sometimes he's a bit old as well. So he's got arthritis. So it's, once again, it's not very specific. In the worst case, we can have compression or impingement in the spinal cord, and sometimes neurological symptoms, which are once again due to metastatic bony disease, obviously with different settings. So metastatic disease is as well non-specific unless it presents acutely, like for example with a cord compression. This is just some examples of non-small cell lung carcinoma, basically, as we said, and the location. And an example of small cell lung carcinoma, which is more centrally located. How do we diagnose it? What would be our management? See a patient. Basically, the first step would be, the simple one, just get a chest X-ray. On chest X-ray, we might see a nodule, a mass, an infiltrate, anything suspicious that we can't really think of. It's not really consolidation. Sometimes you can have a wide mediastinum, but as well, you have to think of other conditions causing it. Hilar enlargement is quite suggestive as well, and pleural effusions are non-specific again. So, but a nodule mass or any suspicious infiltrate should be guiding you towards investigating a bit further. How do we confirm suspected diagnosis? Usually bronchoscopy is the next step, which is it is relatively a non-invasive procedure, and you can give accurate diagnosis because we actually can take biopsy at the same time, send the tissue, analyze. Sputum cytology is not, that's something part of the diagnostic pathway, but it's not that commonly used. And then obviously the next step would be going for sometimes for a needle biopsy, and obviously once again the CT. Why do we do a CT? Not only to look for a precise location of the tumor, but also to look for metastatic processes. That's what we call staging CT once we have a suspicion of a cancer or sometimes a histology already. I just thought I'd mention you something that you'll see quite often in the literature or anywhere, like you'll see CT reports or MRI reports that say, okay, breast cancer T3N1 M0, and you think like, right, okay, that's fine. And they ask you, and then you call the oncologist or the radiologist, and they ask you, right, what's the staging? And so just basically, I'm sure you probably already know this, but basically in the TNM staging system, T refers to the primary tumor, whether actually there is or no. So all the tumors obviously will be primary T1. TX, that's something TX will not see very often, basically, when the tumor couldn't be assessed or there is no evidence. And the T1 to 4 refers to the size of the primary tumor, once again. L refers to the lymph node. I had corrected it, it's not the lymph nodes, it's the lymph node involvement. Right, so whether we have lymph node involvement at all, yes or no. So that's what we said with N0 means no lymph node involvement, NX means we couldn't assess it. And then we have stages like 1 to 3, saying, and N1 means that all the lymph nodes involved are on the ipsilateral size, but it's something N2 and 3. And M refers to the metastatic involvement, saying like, are there any metastatic changes or not? Are they distant? Yes or no? So just the reading pattern and a staging system that is used for all tumors worldwide. Management, surgery is still the treatment of choice for grade 1 and grade 2 tumors. This can be for lobectomy, pneumectomy, but that's something obviously we'll learn further down the stage. We won't be really, dealing with it as FY1s, but just it's good to know. And the vast majority of patients at some point will require chemotherapy at some stage of the treatment. And radiotherapy can be offered as a first-line treatment only if the treatment is non-resectable, because resecting the tumor is still a priority, getting rid of as much abnormal tissue as we can. The 5-year survival is not that great. I mean, it's very variant. Localized disease has quite good prognosis. 1 in 2 patients actually survive quite a while. And 16% for regional metastatic changes, and only 2%, for example, for distant metastatic disease. So it's quite poor prognosis is still. Right, next, I just thought, like, I've talked about women, something common, and then prostate cancer, one of the leading causes of death in men still. Clinical presentation, so we see a 70-year-old gentleman, he's a bit, obviously he has some dysuria, sometimes he goes to, sometimes he's dribbling a bit, sometimes he's struggling to wee, sometimes he's going quite often at night. It's really non-specific, he's 70, 80-year-old, that's something you, once again, would expect. So the symptoms are relevant to the urinary tract system, but once again, not specific of prostate cancer at all. What would allow us to go further down the line of diagnosis is a simple physical examination. So the digital rectal examination is still the first line. The first procedure we would do, first examination we would do basically, but it wouldn't allow us to tell whether this patient has benign changes of his prostate or BPH, or actually to tell the difference between a tumor just on an examination, unless we are urology experts and you get trained there. But obviously, as junior doctors, it's unlikely that we'll be able to make the difference based on the examination. Elevated PSA, you all know what PSA is. The important thing is that any level of PSA basically cannot rule out the disease. So having a high PSA is very suggestive of the presence of the disease, but having a low PSA doesn't necessarily rule out its presence. So that's important to know. But the risk of cancer obviously increases with the level of PSA detected. So the management is, as I said, first line prostatectomy, radical most of the time, radiotherapy or active surveillance. Treatment decision is mostly based on the patient's age, the patient performance status, the extension of the disease, localized or metastatic, and we also, so all those three, prostatectomy, radiotherapy, and active surveillance, can be argued for actually, and depending on the patient case. In a fit gentleman who has a life expectancy between another 10 to 20 years, you'll probably undergo the entire treatment, and with a high PSA, rising PSA, you would probably undergo prostatectomy, radiotherapy. In some patients, we can decide that actually the disease is localized, PSA is raised, but patient's already pretty much 80 or 90. His life expectancy is in the terms of, less than 10 years, for example, both ways. So we clinicians might decide actually that, we only need to keep an eye. Keeping an eye doesn't mean doing nothing. It means having regular examination and PSA levels checked. So it is a way of treatment as well. It means also that at the first suspicion of worsening disease, we will start some treatment. For patients who undergo surgery, a bad sign obviously is another rise in PSA levels post-operatively, and any successive rises in PSA are a bad prognostic factor. Have you heard about the Gleason score as well? Yeah, okay, so that's also, it is a tool that is quite important. It's still arguable about histologic features, but it is used as a tool in deciding on what treatment patients are going to be offered with prostate cancer. Right, and I think also that you, as I talked about prostate cancer, actually have to look maybe first about benign prostatic hypertrophy, but I thought like we can go that way as well. So the main difference, does anyone know what BPH is, what the risk is? is it quite normal to have a... So basically, yes, as I said, like 90% of men by 85 or 50% by the age of 60 will have a benign BPH because it's just part of the aging process on its own, and it does depend on the levels of testosterone. Clinical manifestations are very similar to those of prostate cancer, so voiding dysfunction, UTI-related symptoms, and the complications. It is important to know because that's something you can actually have on the ward, and most patients are on elderly wards, or most elderly patients have BPH, and they are always at risk in becoming acutely unwell and having acute urinary retention, sometimes renal failure in extreme cases. They are more subject to UTIs. They can also present with hematuria or have bladder stones. So for asymptomatic patients or mildly symptomatic patients, we most of the time do a watch and wait approach, or we can decide on medical treatment with those symptoms, but a watch and wait approach is quite sensible in mildly symptomatic or asymptomatic patients. For patients who become symptomatic with bladder outlet obstruction, then they can undergo what we call transurethral radical prostatectomy, which does help relieve symptoms. Once again, physical examination, digital rectal examination. We try to estimate the size of the gland. So normal prostate is something about like up to 20 grams of tissue. It's really hard to say that because that's not something you see. Actually, it's something you can feel. So while performing it, basically we tend to, there's a guide saying look at the number of finger breadth wide and estimate the size of the prostate. So for example, one finger breadth is something like 15 to 20 grams of tissue. So when you have actually tried to estimate the size of the prostate, that can give you an idea, because otherwise you can't see in 3D, and that's something you have to, that comes with practice, so just use it as a guide. We also try to assess the tone of the pelvic floor, the frictions, the pain sensitivity, which is important, because asymptomatic patients having painful examination can be suggestive of prostatitis, so it is a symptom. So those are all the things you can actually look during your examination, and you'll be quite often asked to do it. Okay, this patient, check here that his prostate is not enlarged. So yeah, we have to do it, and sometimes based on what we say, we're going to go further, do we suspect something or not. So it's just very easy, and that can be quite useful in this condition to start with. And the last one is colorectal cancer. So I'll just have a few slides. I'm not going to go through in depth pathogenesis or anything. So 98% are adenocarcinoma, and we see that basically where they develop is really variable about every, we can say, effect in cecum, rectum, and